Thanks to our audience for all being here. We're really excited about this session on addressing social determinants of health in hospital patients. Alongside the new requirements from CMS Quality Reporting Program, the TMF Health Quality Institute has been instrumental in helping hospitals adopt NMDOH measures. To support hospitals in addressing NMDOH, they hosted a series of affinity groups, and these groups of like-minded hospital professionals reviewed, planned, and developed lessons and best practices for NMDOH screening in hospital settings. We're happy to have Kelly Morrison here to talk about this approach and share findings, discuss topics and resources to advance hospital implementation of NMDOH screening efforts and reporting progress. Kelly is an education specialist and health equity advisor with TMF Health Quality Institute. Ms. Morris works in the Quality and Innovation Network and Quality Improvement Organization team. In the most recent scope of work, she focused on providing education and resources to nursing facilities within TMF's designated region, while keeping a focus on person-centered care and non-medical drivers of health. She has 16 years experience working in the health insurance industry, with 5 years experience focused on Medicaid and Medicare HEDIS quality improvement and education. Over to you, Kelly.
Thank you very much for that introduction. All right. Before we get started today, if any of you are not familiar with TMF, I'm just going to give you a little bit of information about the contract that these affinity groups were actually created for and that we worked with. This was the Hospital Quality Improvement Contract, also referred to as HQIC, HQIC. Of course, this was a CMS contract. As Jackie mentioned earlier, we do a lot of government and federal contract work. So this particular program spanned from September of 2020 through September 2024. While they were working on reducing all-cause readmissions and patient harm, of course, it's easy to see how those non-medical drivers of health came into focus and were part of the focus of this contract. You see listed just for informational purposes on the right side of the screen, or left side, let me get my left from my right, the left side of the screen in that gray box, those were the states that were included in the region that we worked with on this contract. So, of course, the affinity groups are what we are here to talk about today. But before we really get into that, I want to give you just a little bit of background about why these affinity groups were so important. I'm sure that being here on this webinar, you guys are already aware that non-medical drivers of health are very important, but this is just a little bit of information and background for you. First, I wanted to share an article from BMC Public Health, and this article actually stated that nearly 80% of the reasons for rehospitalizations and also just for our health status in general are those non-medical or social determinants drivers of health. And you'll kind of hear me go back and forth with that term. Non-medical drivers of health, of course, are what we're talking about here, but the CMS reporting program does refer to them as SDOH, social determinants of health. So you'll hear me say both of those terms, but just know that we are talking about the same thing there. So as Charles mentioned, beginning in 2024, CMS did require that the hospitals that are participating in their inpatient quality reporting or IQR program are submitting 2 new SDOH measures. So we'll talk a little bit more about those in just a moment. But I did want to share this graphic with you first. I know that you've probably seen something familiar to this graphic, but I just think that looking at it visually really drives home the impact. As you see here, if we start up at the head of our little figure here, 40% of the non-medical drivers of health, which are our socioeconomic drivers, have an impact on our health. So these socioeconomic factors, these are your education, your job status, the support that you have within your family, within your community, your friends, your income. So all of the social and economic factors that go into our health. As we move on down on the graphic, 10% is our physical environment. And our physical environment is simply where you live, work, learn, play, and worship. It is your neighborhood. So 10% of that is going into our health. Our personal choices make up 30%. These are the things that a lot of times we do have a choice on. Do we use tobacco? Do we not use tobacco? Same thing with alcohol. Do you drink alcohol or not? Um, exercise is on here, and I know that some individuals are not physically able to exercise, but exercise and diet are classified as well as the health behaviors that you kind of have a control over on your own. And the most interesting fact that I like to point out there is the one at the bottom, healthcare, 20%. So the time that we spend in a doctor's office, the time that we spend in the hospital only makes up 20% of our overall health status. So that's why I really love this image, because you see that huge chunk, that darker blue, green, and orange, that is 80% of what makes up how healthy we are. And it has nothing to do, those factors have nothing to do with being actually in the doctor's office. So that really just tells us why, this effort is so important. As I mentioned, of course, these affinity groups, it was kind of all brought about. One of the drivers for the affinity groups was the implementation of those new measures. So when CMS implemented this program, they identified 5 SDOH, or non-medical driver of health domains: food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety. Now, I'm not going to spend a lot of time on these because, again, we're focusing more on the intervention here. But I did share with you a link to the American Hospital Association Social Determinant of Health series, as well as TMF's introductory video to the affinity groups, where we talk a lot more about these domains. So CMS's primary goal of creating these measures and requiring this reporting, of course, is reducing readmissions and improving health status of Medicare and Medicaid patients. But overall, we are wanting to make sure, well, they are wanting to make sure, I say we because we work so closely with CMS, but they are wanting to make sure that hospitals are collecting this data and that they are really collaborating not only with the patient themselves, but also with the community. So when you identify a need, it's important to look out to see what community-based organizations are there that can help with this need that you've identified for your patient. And also, a secondary goal is risk stratification. Anyone who has worked in any pay for performance projects, or any type of those incentive programs, knows that risk stratification plays a huge role in that. So pulling this data out, incorporating this data into your regular clinical data that you are already obtaining, is going to also help with that risk stratification. So just to kind of sum up this introduction before we kind of dive into the affinity groups more, these are the actual 2 measures that we're referring to when we talk about the program. There is SDOH1, which is the actual screening. So that's where you're looking at the number of patients aged 18 and older who were screened for social drivers of health. And then SDOH2 is looking at that positive rate. And what that means is how many of those that were screened triggered, that there was an SDOH, there was a non-medical driver of health that was affecting their health. So that is that second measure. So, all right. So, starting to talk about our affinity groups, how can we really help organizations make sure that the data that they are pulling is meaningful and that it is actually relating to improved outcomes? Um, Considering readmissions, looking at that non-medical driver of health, how is what they are obtaining going to help to reduce the number of patients that are going to the hospital? So are they doing a constant review of data? Are they constantly identifying areas for improvement? And then also, we wanted to try to help our hospitals with developing targeted solutions for their populations. Because I mean, even if you just look at, and we work with more states than just Texas, but even if you just look at how diverse the state of Texas is, really trying to help hospitals to make sure that they are targeting solutions for their specific population. And then, of course, we can't improve what we can't monitor. So, helping them with tracking and monitoring their progress. So, if you have not participated in an affinity group before, you may be asking, what exactly are we even talking about today? So, an affinity group is defined as a group of people who are working together that share a common interest, background, or goal. We looked at individuals that had challenges and barriers in obtaining these non-medical drivers of health. And we really pulled a lot of those different hospitals together to try to talk about how they can improve on that and how they can use that data to reduce readmissions. We developed these groups and they met monthly. It was a 3-month series. And we allowed them to share tools and resources, not only that they had, come upon on their own, but we also talked about a lot of tools that TMF developed, and we took information back from some of those facilities that worked in the affinity group and even shared that with some that did not. So it really was a big networking project as well. So just, here's an introduction. This was just I really like everything that our communications department comes up with, but I wanted to share their cute little image. This was part of our Cultivating Your Patient Safety Environment series. So this, of course, was the social determinants of health specific group within that whole series. This group had 3 sessions. Of course, our first session that we did was really focusing on those domains. I mentioned you can go and watch that video if you do have more questions about those 5 domains. The second session is where we talked about different screening methods and coding for the social determinants of health data that you obtain. And then, of course, session 3 was understanding and documenting Z codes. We'll talk a little bit more. I have a slide coming up on Z codes more towards the end. But so I'll give you a little bit more of a description of that if that is something that you're unfamiliar with. But one of the things we were really proud about with these affinity groups were the 3 videos. So we did have the actual affinity group sessions, but each session had a video to accompany it. I'm not going to show the videos today. That would take a little bit too long, too much of the presentation up. But those links that you see here, I know Jackie mentioned we would be sharing the slides from this presentation. And those links that you see here, they are live links where you can go in and watch those. There's a lot of valuable information. And we created those so that you can go back, well, not only you, but also the hospitals that participated in the affinity groups, those that missed out and weren't able to participate, we were still able to share this information with them. I know, as Charles mentioned, I was heavily focused with our nursing home facilities on the last scope of work, and we even shared a lot of this information with the nursing homes because that was something that they kind of struggled with as well. Is how can these non-medical drivers of health affect our patients? So these videos, I hope you find them very useful. I would definitely recommend checking them out. So when we get into the actual structure of the affinity groups and really talk about, what was our process, this is kind of a summary here. Each of our affinity groups, this first line that you see here is more stuff that was going on in the background, but it's very important, especially if you are thinking about, running some affinity groups yourself. We had designated staff for each session. We had a facilitator. Of course, that was the person on the line that was kind of running the session in the background. We definitely made sure that we had at least one or more subject matter experts on each of the topics that we were focusing on during the group, so that there was someone there to answer questions, even those really tough questions that all of us might not know. We had a chat monitor. We utilize our chat function. I think we did these in WebEx, and we utilized the chat function in WebEx for questions. So we had someone that was literally just their job was to sit there and watch those questions coming in, so that they could make sure that we didn't miss anything. We also had a chat poster. And what I mean by that is if we were sharing links, if we were sharing valuable information, that chat poster was putting that information in there so that our, attendees could, right as we spoke about a link or right as we spoke about a specific resource, they could click on it and open it up and have it saved on their computer right there for them. And then obviously a note taker, someone who was able to, make sure that they got all the Q&A questions so that we could share that. We always wanted to share that information in a post-event email, as Jackie mentioned that we'll do today, so that we could make sure that we were sharing all of those Q&As in case anyone missed something going through the presentation, and also resources. One thing that we did is we did not record the sessions. I know most everything that you attend now is recorded, and that is an excellent thing. I mean, I record most of the sessions that I present as well. But, based on the feedback of our hospitals, we learned that they were a little nervous to share their questions and really to share their experience when they were being recorded. So, that was another reason that we did those instructional videos that went along with each session. So you could go back and, rewatch the information that we were talking about. But honestly, not recording the sessions really encouraged sharing. Um, so I think that was kind of a unique thing that we did with this group that we even TMF, we don't usually do. Typically, we record all of our sessions as well, but we found out that we had a lot of collaboration within the sessions. With them being free to share, hospitals with success stories in the topic areas, they were more willing to share their success stories, and they were also more willing to come forward with challenges. They weren't quite as embarrassed about things that weren't working for them. And it was really great to see, during that networking process, you have hospital A is over here talking about their struggles with screening and not being able to, draw information out of the patients. And maybe hospital B in another city says, oh, well, we had that same problem and here's what we did. And it's just really a good thing to see them working together, when you kind of just bring them together and facilitate that. So we'll move on to more of a negative slide here. These are some of the challenges and barriers that we identified. Initially, one of the barriers was basically just a lack of definition of what are non-medical drivers of health. What is CMS saying when they talk about SDOH? One of the really good resources that we found to share was the Gravity Project. So again, this is a live link on the screen for you. We'll share that with you after the session as well. But the Gravity Project, it's like an open public collaborative, and they focus on social data standardization, a lot of health equity topics. So they have really good resources and workflows on their website. If you have not already, I would definitely recommend checking them out. Screening tools, that is another thing that we heard a lot of struggle with. That is one thing that I actually noticed that I forgot to include the link within the slides, but TMF did work internally and with some of our hospitals to help to kind of create a screening tool that gave them kind of like a script to go down. Here's what's to say if you have this struggle with this patient. And here's how to try to draw this information out. So we will definitely be sure to share that one with you because that was a good one that we developed that was used. Of course, you see just some more common things on here: workflow of coders, unfamiliarity with the social needs of your community. Like I said, Texas itself, I mean, is a very diverse state. There are a lot of, you may work in a city that you don't live in, and you may be unfamiliar with the specifics of that community where you are working. So that was another thing that we really talked about, is looking at, community assessments. If your hospital doesn't do a community assessment, typically there are lots of organizations out there that are doing community assessments. So make sure that you are reviewing that information so that you know the needs of the communities that you're serving. So one thing that I wanted to share with you guys is this is kind of a case study, or you could say success story. We did have one of the hospitals that attended our affinity group, a very small hospital, South Texas. There actually, it was a 15-bed critical access hospital. And they identified through beginning working with these screenings that they had a very large number of Spanish speaking patients. However, another thing that they realized was that they weren't really consistently using interpretation services that were available and translation services that were available. So they as a result, of course, without using those official services, they were asking like their bilingual colleagues to come over and, help with this patient, or heaven forbid, and I know it happens all the time, family members assisting. I mean, the child maybe being the translator. Um, so they really, when they really started focusing on it, they noticed that this was an issue. So their chief nurse actually teamed up with one of their infection prevention nurses. They evaluated the process that was currently going on, and of course noticed that there was a lack there. And they used CMS's guide to developing a language access plan, and actually came up with a very successful plan. They are now translating. They started with one, and this is another thing I like. I'm also a instructor for CPHQ for NACU, so I'm really big on quality improvement, PDSA cycles, and all of that. So they did a small pilot with their laboratory services and started doing translations, and seeing what the success was there before they rolled it out. But they actually ended up with a very successful outcome. And I love the quote that's on here. This is an actual quote from their chief nurse, which is exactly what we're talking about. Once they started this webinar series, it made them think about the background of the community that they're actually serving. And they started looking at those individuals' needs rather than just trying to, get through the day and get your processes and get everything done. So I think this is a really good example of how, when we look at those challenges that were on the previous slide, like the lack of the screening tools, not having the operational process in place, not knowing what the social needs were, really digging down and focusing on correcting those issues by educating your staff, doing the screening of your patients for their language preferences, and then of course that language access plan. So I like to share, something positive, not all the bad stuff when we're talking about the challenges. So I think that this is a really positive story that you can see that was an outcome. Just to speak to some of the tools that were shared, not only with that hospital in the success story, but again, one of the challenges that we heard a lot was the need for screening tools. So, of course, CMS within the program, they don't require a specific tool, but they do recommend some. And the health related social needs screening tool is one that we shared. That is a very highly recommended. Also, the accountable health communities model, the AHC model, is another one that is a very good example. So I wanted to share those screening tools with you. Um, when we talk about the screening tools, one of the questions we got to was, well, what do we do with this information? Um, if you have an EMR, if you have an EMR that is capable, we definitely always recommend trying to incorporate that screening tool into your EMR. Now, sometimes that's an upgrade. I know that can be a financial barrier, but if there's any way that you can embed that tool into your EHR, or maybe your EHR has one and you're just not familiar with it. A lot of times, it's just a switch that they need to turn something on for you. But definitely documenting was another challenge. So if you can get that embedded into your EMR, I definitely recommend that, because a lot of times once it's in there, it can automatically kind of correlate with, your evidence base, making clinical decisions, helping with discharge planning, and it can just automatically do all that for you. So if you have that option, if you're not sure if you have that option, I would check with your vendor to see if that is anything that is feasible for you. Let's see here. So when I say EMR, of course, you got to have codes to put in there. So that's where I'm going to pull back in and talk about Z codes very shortly. Um, some of you may be familiar, some of you may not. I was actually kind of shocked to know when I was doing the research for this that Z codes were actually introduced way back in 2016, but it has been kind of a slow adoption. They are, of course, just a subset of the ICD-10 codes. But the different thing about the Z codes is they are the ones that are specifically reporting those non-medical drivers of health. So if you're not familiar with the Z codes, go back and watch our video. I think it was the third one that is specifically educating on the Z codes. And definitely, try to educate your staff, make sure that you are aware of that, because again, if you can get these into your EMR, I really think that it would be beneficial for you, because a lot of that stuff will kind of start being automated in that case. All right. So just to kind of summarize, again, our intervention that we felt was very beneficial to not only us, but also to our hospitals, were those affinity groups. Um, the greatest benefit we felt like with our hospitals, of course, was that networking. Again, it was just beautiful to see how, you can be talking about a challenge, but there's another hospital that they've already experienced that, and they're going to help you go through what helped them. We definitely connected as well. One of the benefits for the hospitals was that each of the hospitals were kind of assigned, or they connected with one of our quality improvement specialists. So that allowed for one-on-one technical assistance that happened outside of the affinity groups. So that is also a great benefit that we had for the hospitals. And with TMF, we had a lot of benefits as well. We were, of course, doing our contract. We were actively working with these hospitals to reduce patient harm and to reduce readmissions. We were identifying hospitals, not only those that had the challenges, but the ones with the best practices, such as that, success story, so that we could share that information. And of course, anytime we're teaching something, we always learn as well. So we also increased our topic specific knowledge within our team. I know that we're kind of getting close to question time, so I'm not going to talk a lot about these next slides, but this is just kind of a feedback slide that we like to share. This just shows how many times each one of these videos has been accessed. So we are very glad that we shared them, because obviously, the facilities and the hospitals are using them after the fact. So these numbers continue to grow. I know every time I do any type of presentation or paper on this topic, we have to go out and research to see how many more clicks we have now. So that just kind of shows you that the sources are being utilized. And then these are just a few additional resources. These are some of the more popular ones that we did share through the present or through the affinity groups. Of course, those screening tools. The prepare tool is another one. I didn't mention that back in the slides, but that is also another very good tool that you can check out. There is another screening tool here from the AAFP. And these are some good resources from the American Hospital Association. This gives some really good guides. This is good to help you once you have identified the need. What can you do to address it? So food insecurity in hospitals, housing in hospitals, transportation in hospitals. So these are some other really good guides that can help you once you get to that point where you have identified some needs. All right, so that is it for me. I have included my email address also on this slide. So later on, if there are any specific resources that I may have mentioned that you can't find in the presentation, or if you just have any general questions, please feel free to reach out to me. And you can also follow TMF on Facebook. We like to post resources and different events that we're having. So if you click on the little Facebook icon, that should take you to our Facebook page to follow us there. So I thank you very much for having me, and I will open it back up to Charles and Jackie for questions. Thank you.
Thank you, Kelly. That was great. Please, if you have any questions, please raise your hand or drop the raise your hand feature is under the React button, or you can drop your questions into the chat. Kelly, I know from talking to a lot of programs around the state, when you're innovating and designing something new, it can feel a little isolating. So what a blessing to kind of come together as a group and be able to share those experiences in a safe environment. And it's a great perspective you were able to share with us here in your presentation. So thank you for that. One thing with screening that we hear people talk about is, do people get uncomfortable, in answering some of the questions, both the patients themselves, but also the provider and how they collect that information. So what did you hear from your affinity groups on that issue of comfort level with the screening?
Exactly. So that was definitely something that we heard a lot. That is where we really felt like the script came in, because not only does the script give you like specific examples of asking about living situation. I mean, you can just as casually as possible, but just making sure, do you have a safe and stable place to live? Who do you live with? Do you have pets? Do you have, just asking it in a very common way like that. It also, in the script that we developed, we gave tips as far as, have a very warm and personal approach, smile, make eye contact. It does take practice. I mean, I know, because like you said, even for the clinician or for the intake, whoever's asking the questions in the facility, it's a little bit unnerving for them as well. And these are uncomfortable questions. So, it even takes practice. I mean, practice with your employers. That was with your fellow employees. That was one thing that we told them. Practice at home, practice on your family. But really try to just, make eye contact, be warm and inviting. So we definitely tried to focus and call out those types of things on the script.
Well, we always refer to our audience to the great repository of kind of the scientific or the research information on these same topics at
Hmm.
Siren, which is the University of California, San Francisco. And,
Yes.
the research studies show, both the provider and the patients, really have satisfaction and feel like there's a true benefit, in answering these kind of questions, even though they are sensitive. But, through processes like you're talking about, you can deliver that in a way that feels engaging and comfortable for them.
Exactly. I mean, you're showing your patients that you really care. You're not just giving them instructions on, here is your care plan as far as the clinical part of it, but we're really wanting to make sure that your home environment, are you able to meet these needs? Yeah.
Yeah, exactly. All these are vital to supporting that care plan.
Mhm.
I see a hand raised. Rebecca James, do you want to unmute and ask your question?
Hi, my name is Marisol Rosales. I'm using Rebecca's, I think, account. Sorry about that. Yeah, so just along those lines, I think that
Mhm.
being able to have the resources though available for the patients, it's also something to think about because oftentimes, when we start addressing or we start screening for something, then we find out about the needs and what happens after we find out what they need and we're not able to get them any help. And so do you have anything to share about that and how you help like hospitals look for these resources and how do you go about that?
Yeah, and I'm just going to make a note so I can send this information over to Charles too to share. Okay. Yeah. So a lot of the resources that we would recommend are, like the 211 resource that I believe goes through United Way. And 211 is an excellent resource. I mean, you can go in there and find assistance for just about anything. Like you can look at the topics and it'll guide you to somewhere within your specific community. You tell it where you're located. Also, it used to be called Aunt Bertha. I think it's called, um, oh, I'll have to Google that. I'm sorry. Or wait, I think I may have it pulled up here somewhere. I'm sorry. I've got so many different, let's
We've
see.
had
Aunt
we've
Bertha. It's
worked with
findhelp.org. Oh, I'm sorry. Go ahead.
we've tried we're working with a platform called Unite Us now, and we're trying, and
Oh,
we're
yes.
over here in the valley, in the Rio Grande Valley, and so we've tried to get organizations on there to actively be using that so we can really know and share those resources with each other. But I think it's taken a while, and so um uh, tried 211 also. We've tried different avenues, but um there's some things that
So
don't,
you're just kind of having in your area, there's just kind of a struggle for, is that what you're
well,
saying? What?
and a struggle getting resources, like for the reason that
Okay.
sometimes there's no, no help with transportation and things like that. So just
Hmm.
knowing, I guess the limitations as far as, because I know that it can get hard when we're asking patients to share this information and then we don't offer the help,
Right.
right? Because there isn't any. And so I just kind of wanted to touch on that and how important it is that we do, we do it very carefully, as you're saying, because sometimes we can't help.
Mhm. Oh, exactly. I agree with that. I know in some areas there's just not, yeah, there's just not any assistance. But yeah, and thank you guys for putting that in there for me. Aunt Bertha is now findhelp.org. I don't know if you've looked at that one also. Okay. All right. Sorry. But another thing that I might suggest to you too is reaching out to other local hospitals just to see if they are also having these same issues and if they have had any success or if there's anything that they found. If you have like a coalition or anything of that nature, that could possibly help.
Great question, Marisol. I'll tell you that in
Mhm.
the current legislative session here in Texas, there is a bill that's encouraging or creating a mechanism for so the 211 system has a more standardized approach to assessing
Mhm.
non-medical needs, and it has some navigation for helping with that. So the policymakers are, looking at that system as one of the solutions that we could apply here. Dr. Collins, I see you had a question in the chat and your hand's raised. So I'll let you unmute and ask your question.
Awesome. And my question has been answered. So thank you for in terms of what is
Oh,
the next step, because the assumption is made that we empower the patient, but oftentimes capitalizing on their visit is where we will, kind of maximize providing, services that they can really take advantage of. So a few things in terms of, there is growth across the country in terms of medical legal partnerships in which you work with sometimes there are law schools to provide information. I know that you have a webinar that's, I would highly recommend others to take part in to really talk about that as an opportunity. But also in terms of our promotoras and patient navigators, there might be ways in which they can also be utilized, because having that kind of responsibility of the provider or practitioner, we already hear the challenges that they face in terms of utilizing the options on our electronic health records, for example, in terms of the social determinants of health related Z codes, right? And so again, we're not there yet, but all those things I think will be important to kind of, utilize. Not just one thing is going to get us there, but again, just suggestions and recommendations. And thank you again for offering this webinar today.
Thanks for being here.
Thank you, Dr. Collins.
Another question we had was, in the affinity groups, what are you seeing for which provider types are the ones who are meeting with patients to discuss resources and how to act on the positive screen? How do they learn what to do?
Honestly, it is pretty diverse. I mean, sometimes I think it depends on the size of the hospital, but really, I mean, we were hearing from, the MDs themselves to, as Dr. Collins mentioned, possibly it is your patient navigators, community health workers. So not only that, but a lot of times, especially in some smaller communities, they've even considered using faith-based leaders. So you can refer the patient to a faith-based leader or programs, what is it called? The community-based services that they have through Medicaid. You can refer your patients out to those types of services just because, I mean, in addition to like the 211 and the help.org, those organizations are targeted right there in the community. So they may know something that, some bigger organizations not aware of. So it's really a variety. Even like EMTs, I've heard of that, paramedics working to help identify and also to help once there has been something identified. Something also common is tribal resources. So, we have a lot of American Indian, large populations in Texas. So sometimes tribal resources as well.
Great. And I know here in Texas, there's been a really strong interest in doulas for pregnant and parenting.
Oh, right. Yeah. Mm-hmm.
We've got another question from Diana Ruiz. Diana, do you
Okay.
want to unmute and ask your question? If not, I can ask it for you. So she's asking about selecting a tool. Like some of these tools are kind of long, some are shorter. How did your affinity groups kind of think through that selection of instruments and weighing, the cost of how long they are versus how much information you're gathering?
Oh, right. Well, I mean, obviously we started off by looking at the CMS recommended, because that's always going to be your first step. But then with some of the larger, longer questionnaires and the tools that were a little bit more lengthy, really just working one-on-one, like I said, we assigned, all of the hospitals had a quality improvement specialist that was assigned specifically to them. So, I mean, you could kind of go through that with your QIS and make sure that if there are additional questions on there, if there are a lot more questions than maybe say the one that CMS recommends, then it may be something that is specific and useful for your community. So that's what I would really recommend, because you don't want to take up half of the visit asking a very long questionnaire. I would say to even, since CMS doesn't require a specific one, you could even kind of take a questionnaire and fashion your own from it. You know what I mean? Like you could remove certain questions that aren't really pertinent to your population and add some that may be. I hope that answers that question properly.
Thank you.
Diana. Yeah, of
I,
course.
I liked how you talked about the importance of, getting this information into the electronic health record, because then that unlocks a lot of other utility of that information. So one of the questions we had from Karen Zisk is, what about closing the loop on those referrals? How do we get like that information on what happened with the referral back to the provider or in the EHR? Did you all get into that?
Not very much. That is actually that's a hard one. I mean, that is hard even when you're talking about just regular clinical care. So we didn't really get into that a whole lot during the affinity groups. But what I would recommend on that is just, make sure that you have a really strong and passionate, if it's a nurse or a patient navigator, whoever you have that is responsible for kind of managing this data, and just make sure that they are in a good practice of following up. Because especially if you're referring to or using organizations that don't have an EMR, which is going to likely be the case, with community-based organizations, then it's really harder to get that back.
You're mentioning the utility of Z codes, and it looks like from national data, it's been kind of slow with getting
Yeah.
uptake on them. Did you hear any of the organizations in your affinity groups talking about like how to encourage or incentivize or get more use of the Z codes?
Really just with education through staff, making sure that the staff understand the importance of it, is really the main way that they were trying to increase that use.
I know participants in your groups were across several different states. Did you notice any trends in Texas, like kind of unique challenges or ways of approaching solutions in Texas that were different than other states?
Well, I will say that Texas is very, I don't know, I don't want to say competitive, but they want to be the best. So we did see a lot of really good, I guess you could say, gusto with really getting in there and trying to implement everything. But not a whole lot. I mean, as far as the challenges, honestly, the challenges were pretty same, even among different states, just because a lot of it, especially with the documentation pieces, that's definitely pretty much a across the country challenge with getting what you need out of your EMR.
Makes sense. I think one of the attractions of an affinity group is that peer-to-peer learning and those connections. Once you were done with the kind of the curriculum that you had for them, did you see any kind of lasting collaborations or ongoing, dialogue between peers that you brought together?
Yeah, so it is fun. I mean, even other webinars that we have, webinars that we host, it's really great to even see little stuff like you'll see in the chat somebody saying hi to somebody else. It's like, oh, hey, remember we worked on such and such together. So, I mean, I really feel like based on seeing that yes, that we have hopefully built some lasting relationships between our facilities. Definitely.
You really dug into, how to address those positive screens, and just what were the kind of most common screens that were positive, and were there any particular ones of those that were, easier or more challenging to address by the system?
Some of the more common, I mean, food insecurity was seen. Of course, language access, that was a huge one. And we actually even did an additional series on implementing class for language and access. So that was definitely one that was identified. But one of the hardest, I would say, is housing insecurity, just because that is just something that is very difficult to tackle, especially from a hospital perspective. So I would say that would probably be one of the places where we saw challenges Again, a lot of times we would just suggest trying to reach out in your community and have a list of shelters, utilizing the faith-based organizations. So, you know, a lot of times those organizations can at least assist with housing temporarily. But I would say that was probably a big challenge.
I know the design of your program, you know, kind of came about through a contract, and I was just wondering,
Mhm.
you know, as you think about next steps or what you would love to do, you know, as an extension of this service, you know, where would you go with this? What would be the next iteration of this approach that you've taken?
So we are waiting on the award for the 13th scope of work contract. I'm sure anybody that's out there in the federal realm is aware of that. But we, you know, depending on what that contract says, I would even like to do kind of a follow-up with this, you know, maybe a secondary series to see, you know, where are you at now from where you were, and just kind of start really digging down more into, since we've already done, you know, the overview and the here's what the codes are and here's what the reporting is, really trying to focus more on locating resources and being able to solve some of those problems that are identified. So we'll see what happens with the next contract, if we can go that direction or not. But
Well, we're getting close on time. I just want to give any last minute questions from anybody who has anything that they didn't hear an answer to already. If you could just raise your hand or unmute.
I'll say I noticed that Dorothy put in that Find Help and Unite Us have closed loop referral options. So that is awesome. I was not aware of that. I've not worked a lot specifically with the programs, more just guiding people to them. So I like that. That's good to know, Dorothy.
Well, not seeing any other hands raised. Let's see. I just see in the chat, Alicia Elam dropped in Connect ATX United Way is who they use for their close referrals thing.
Okay, cool. Thank you.
Not seeing any other questions. I'm gonna turn it over to Jackie to close us out.
Thanks, Charles. And thanks so much, Kelly, for this robust presentation. These convenings are really critical to advance the NMDOH work here in Texas. Before we wrap up, I want to invite you all. I want to invite all health organizations to be a part of our growing NMDOH program index. For those of you serving patients at healthcare organizations, we want to hear how you are meeting patients' non-medical needs through non-medical intervention. We are looking for health systems, hospitals, clinics, and health plans. This is an exciting opportunity for you to showcase the various ways that healthcare is already addressing patients' non-medical needs in Texas. The index is a resource for providers to learn who is doing what for which patient populations. It can also be a resource for policymakers to see how the healthcare system is meeting patient non-medical needs and make policy change in favor of sustainable payment. The program index is as robust as we make it, so I look forward to hearing from each of you. The link for the program index is in the chat. Please click that link and bookmark it for when you can add your information at a later time. For any questions, you can message me at jk90@rice.edu. Thank you so much for taking the time to join us today, and please look out for meeting materials in the coming days. We will include a link to suggest ideas for future webinar topics and encourage you to tell us what you would like to learn about as we build the field of practice for the non-medical drivers of health. Thank you so much and have a great day, everyone.
Thanks, everybody.
Bye.
Nice seeing you.
Thank you.